This video is on inflammatory bowel disease. The two types of IBD are ulcerative colitis and Crohn's disease. They result from an inappropriate immune response to endogenous microbiota within intestines. Specifically, T-cell activation leads to unregulated cascade of cytokines such as interleukin-1, interleukin-6, and TNF-alpha. This results in fibrosis, collagen production, metalloproteinases activation, and the coagulation cascade. Cytokines can also recruit other inflammatory cells, such as macrophages, B cells, lymphocytes, and leukocytes. That is the general process, but let's look how this manifests in ulcerative colitis and then Crohn's disease. Ulcerative colitis affects the rectum to the colon and is a mucosal disease without skip lesions. A colonoscopy and gastroscopy investigates the macroscopic appearance. Mild disease would be erythematous and granular, like sandpaper appearance. Severe disease would have erythema, hemorrhage, and ulceration. Pseudopolyps reflect epithelial regeneration and hence would indicate long-standing disease. A biopsy would show microscopic features such as crypt abscess shown here, and infiltration of inflammatory cells such as neutrophils, plasma cells, macrophages, and lymphocytes, resulting in vascular congestion, edema, and hemorrhage. You can also get something called backwash ileitis, indicated by villus atrophy and crypt regeneration. This underlying process causes the signs and symptoms of ulcerative colitis. Diarrhea is common with rectal bleeding and mucus, also abdominal pain. Tenesmus is an affected colon symptom, which is a sense of incomplete emptying even though stool has been completely passed. It is basically due to nerve irritation. If poorly treated, it can lead to complications. An important but uncommon one is massive hemorrhage. Toxic megacolon can also result in perforation and peritonitis. Also due to strictures and just general cell disruption, colonic adenocarcinoma can develop. Now, Crohn's is a transmural disease with skip lesions affecting anywhere along the GI tract from mouth to anus. Macroscopically, due to stellate lesions fusing longitudinally, Crohn's has cobblestoning appearance. There may be adhesions and fistula formation and fat creeping around serosa. Like ulcerative colitis, there may be pseudopolyps. The characteristic microscopic feature of Crohn's, a non-caseating granuloma, is shown here. Similar to ulcerative colitis, there are crypt abscesses and inflammatory cells infiltrate. Signs and symptoms depend on which area of the GI tract is affected, as remember, unlike ulcerative colitis, Crohn's can affect anywhere. So if it's in the perianal and colon region, there would be similar symptoms to ulcerative colitis, so diarrhea and crampy abdominal pain. If it causes ileocolitis, it can mimic appendicitis, so right iliac fossa pain and fever all cause bowel obstruction features. Jejunal ileitis can cause malabsorption and steatorrhea, which we'll talk about more under complications. Finally, Crohn's in the gastroduodenal area would mimic a peptic ulcer, for example, epigastric pain and nausea and vomiting. Complications include bowel obstruction due to strictures and adhesions. As touched on before, there may be malabsorption, specifically B12, folate, iron, and fat-soluble vitamins, ADEK, resulting in malnutrition as well as electrolyte abnormalities such as low calcium and magnesium. We also talked about fistulas, specifically enterocutaneous, so to the skin, enterovesical to the bladder, or entero. Similarly to ulcerative colitis, there can be colonic adenocarcinoma and perforation leading to peritonitis. An important consideration in IBD is intestinal manifestations. This is in keeping with unregulated inflammation, just not in the GI tract. The skin can have erythema nodosum and pyoderma gangrenosum. Eyes can have anterior uveitis, iritis, chloritis, episcleritis, and conjunctivitis, so inflammation anywhere in the eye. Mouth, you can have aphthous ulcer, joint ankylosing spondylitis, or seronegative arthritis. Hepatobiliary impacts include autoimmune hepatitis and primary biliary cholangitis. Renal includes nephrolithiasis or kidney stones due to basically low oxalate from malabsorption. And finally, vascular effects include vasculitis. Finally, treatments are two stages. Initial is when there's a flare-up, and maintenance that prevents a relapse. Initial therapy includes corticosteroids such as prednisone. Maintenance, there are a few options including immunomodulators such as azathioprine. 5-aminosalicylic such as mesalamine can also be used in ulcerative colitis as it is activated only in the colon. So if it's somewhere else, such as in the ileum, which is affected in Crohn's, the drug would not be activated and hence useless. Finally, monoclonal antibodies such as infliximab may be used. Thank you for watching. If you learned something, please tell a friend who may also find it useful.